which exited through the puncture wound where the neck-defining suture was placed. The midline, most posterior neck-defining suture puncture site is used as the insertion site for the suture rod. Suture rod is then passed in the subcutaneous plane. If it passes too deeply, a dull red light will be seen transilluminating. This means the rod needs to be backed up and re-advanced more superficially. If the rod passes too deep, the muscle may be penetrated and the patient may have early, recurrent, or residual platysmal banding and less than ideal results. The rod is then almost brought out until there is approximately 1 centimeter of the rod in the subcutaneous space. The rod tip is then rotated, allowing the subcutaneous portion to be oriented towards the mediocanthus. It is then advanced approximately 2 centimeters, encircling and engaging these ligaments before traveling back underneath the jawline. The suture matrix is weaved in a crisscross fashion, going to every other mark as the suture is advanced anteriorly towards the submentum. Eventually the suture will be brought out through the submental stab incision where the liposuction access was obtained, as well as tunneling access. When the procedure is used in a patient after a neck lift or other facelift procedure, or even liposuction of the neck, if there is no fat to be removed, only tunneling is performed prior to weaving in the suture matrix. Liposuction is only performed if fat is present. It's important to note that with each passage of the rod underneath the jawline, if there is any difficulty, it is okay to puncture and make a new pivot point underneath the jawline. The rod was designed to be straight and should not be bent during this procedure. Therefore, if multiple pivot points are needed to travel around the curved surface of the jawline, they are necessary and will allow the easy placement of the suture matrix. Once again, illustrating the rod as it is rotated, encircles the ligaments, and then engages and is advanced downward underneath the jawline. With each passage of the suture rod in the subcutaneous space, the suture is grasped by the surgeon and pulled, thus keeping tension on the suture throughout the entire operation. If the surgeon does not do this and reaches the end of the operation with a loop of suture out of the submental incision, it is almost impossible to tighten it at this time, secondary to the braided nature of the suture and the weaving around several ligamentous attachments. Upon completion, the two ends of the suture are tightened, the suture rods are cut free. The assistant puts gentle upward pressure in the submandibular area, thus helping to place tension on the suture matrix. The appropriate amount of tension of the trampoline is obtained when there is visual dimpling of the two anterior anchor points along the lateral ramus, as well as visible tension lines underneath the jawline. This dimpling and the tension lines resolve in most patients within 24 to 48 hours. During the first month, when the patients open their mouth widely, they will note some dimpling, which resolves in 4 to 6 weeks. This illustrates what happens when the suture matrix is tightened. The skin approximates the muscles, thus closing the dead space.